Hey, good evening, and thank you for joining our sixth webinar of our 12-month series, Activities of Daily Living. Our program will be recorded and can be found on our Anthem YouTube channel in the coming week. Please keep your camera and your microphones off until our Q&A portion, at which time you can either type your questions into the chat or raise your hand and we will unmute you then. And we are delighted to bring to you a legend in dementia training, Dr. Tam Cummings. Dr. Tam, as she is known in the dementia community, is a practicing gerontologist who has devoted her professional career to educating both professionals and family caregivers. In 2009, she founded the Dementia Association with the mission to inspire, educate, and empower dementia caregivers. At Anthem, we utilize her transformative work, including the daily conversations with families of those with dementia. If you have not already received your copy of the Itty Bitty Dementia book, you can find one at your nearest Anthem community. Families, professionals, and caregivers, it is an honor to once again present to you Dr. Tam.
Thank you, Chris, and thank you, Anthem Memory Care. Thank you guys for what you're doing. Thank you for having watch parties for our folks yesterday so that everybody who could see it, and getting folks out for a breath of fresh air. That's always such an exciting part of every day. And one of the things that usually catches families off guard, Chris, is most people are unaware that under state and federal regulations in our field, we consider taking a person outside to be a spiritual event. So not only was it apparently I'll never see again in my lifetime, that didn't make me sad at all, but also a spiritual event. So every time we go outside, just getting that breath of fresh air and making sure that that's part of daily activities is such a big thing. So as we get started today, I want to remind everybody that this is a terribly hard journey that you're on, and that you're connected right now with people who know and understand what you're feeling and what you're going through. None of the thoughts that you're having are odd or weird. If you're wishing your loved one could just go to sleep tonight, that's a normal human thought because you're watching a person you love slowly die, and that is excruciatingly difficult. And that journey is at least And so as you go through this journey, especially this last part, which gets even harder, remember to breathe. That we start everybody with is, and breathe through your nose only, don't breathe in and out through your nose and mouth, you'll just get a dry mouth. But breathe in to the count of 4, breathe out or hold for the count of 2, breathe your breath out slowly to the count of 6, and then breathe in again to the count of 4. And by doing this, you begin to slow your heart rate, your respiration, and your blood pressure, and you automatically help your autonomic nervous system kick in its parasympathetic nervous system so that you can calm yourself down. So we ask that you do this at least 4 breaths before you come in to visit your loved one, before you ever get out of your car. Take a moment for yourself to gather your. Remember to do it again when you leave, and when you feel yourself shaken up or you feel yourself getting a little bit out of balance, stop and take a breath. This only takes a few seconds to do. And Chris, if you start doing it for several minutes, that's called meditation. So just remember to stop and breathe for yourself. It's something we forget to do. We tend to hold our breath when we're anxious. Now, today we're going to talk about the activities of daily living, and you need to know the activities of daily living, and it's because these are the things that are failing on your loved one, but they're also the things that we grade people on in terms of progression of the disease. We plan their care around in terms of progression of the disease. It's also things that are indicated for additional care that can't be supplied at home when medical care is now required. Now, the activities of daily living scale, sort of the background of it, comes from a physician named Dr. Katz. And in 1952, he developed a measurable index to look at declines or step downs that occurred during aging. And it was for normal aging or for people who were chronically ill. It was never designed to be used for people with dementia, yet it is one of the most used tools that you will find physicians using, especially physicians who are not specialists of dementia or other medical professionals using, because they don't realize when this tool was built and that it wasn't designed for people with dementia. So you're going to run into the Katz. I sent you one in a handout so that you could get a look at it. And as a family member, when you look at it, Chris, what most families see is that, oh my gosh, my person had to go from here down to here. I mean, there are major step downs on Dr. Katz's scale. And in dementia, we rarely see these major step downs. Instead, we realize that there are spaces between I can dress myself unaided and I need somebody to lay clothes out. And in between that, there is a loss that occurs long before. And so Dr. Katz's scale has been a wonderful tool. It's part of my education, certainly something I have used forever. But Dr. Katz's scale wasn't designed for the population that related or walked to the bathroom or toilet. From there, I did my bathing, my grooming, my dressing. Those are the ADLs. That is all that they are. That's all we do. And that's all we do for your loved one. We can't regrow brain tissue. We can't somehow make them become them old selves again. All we do for them is we add more and more levels of care to the activities of daily living as their brain loses more and more brain tissue and they're no longer able to perform all the steps that are in the activities of daily living. So Chris, are you with me so far?
I am.
Yay, Chris said yes. Now, the instrumental activities of daily living, these are the things that you and I learned as teenagers and young adults. The ADLs are things you and I learned as and children. Lawton-Brody in 1969, the doctors, Dr. Lawton and Dr. Brody, came up with the instrumental activities of daily living. And as a family caregiver, Chris, when you and I look at this, when I meet a family, I realize you're the one doing all of these things. Very, very slowly, you begin to take over these duties. And ladies, if you're watching this tonight, if you were a woman being graded on this scale, you were graded on all 8 categories. If you were a male being graded on this scale, you didn't get marked off for laundry, housekeeping, or food preparation. So, it came from 1960. So we look at this and we know this is part of why you're exhausted as a caregiver is because very slowly over the last 10 years, you begin to take over these tasks for your loved one. And, there is some levity there. My father wouldn't know dirty laundry if he fell head first into it. I'm not even sure he knows where the utility room is. He gets out of dirty clothes, they disappear, and when they come back, they're hung in his closet, they're folded and put away in his drawers. We know of ladies who never did the finances because that was considered her husband's job. So when we would tell families to look at the instrumental activities of daily living, we would tell them to give an account for if your person would actually really not know how to do this. But it was designed with the understanding that women were expected to do all of the tasks, whereas men were given a pass on it. And as a family caregiver, one of the reasons you become exhausted, one of the main reasons that you tell me, for example, that dementia only began 3 months ago, 6 months ago, a year ago, is that you don't realize for the past 10 years, these are the things you've slowly taken over. So Chris, I know men who've never cooked for their wives from the day they got married. That was her part of the marital contract. That was what she did. She was the homemaker and she took care of the kitchen, to where he then had to begin to buy the food, cook the food. And in the process, one gentleman in particular said he noticed there was a day where his wife no longer understood how to, because he had broken down the task that she had done for food preparation to little things that she could do. But then he had realized bit by bit and piece by piece, each of those little tasks was gone until she no longer understood how to clear the table and bring him the dishes to clean, to where she certainly didn't understand how to wash or dry at that point. And so the reason you as a family member have a hard time hearing us say you've been a caregiver at least 10 years is because the movement of the disease is so slow, but so insidious that bit by bit by bit, you begin to do everything for your loved one. And that is what leads to the caregiver high levels of stress. By the time we meet you, that's push towards the caregiver death rate, is because for so very long that you don't even realize you've been doing care. Does that make sense, Chris?
That does make sense.
Okay. Well, then we come to a scale called the Bristol ADL scale, and it's from the Bristol Medical School of Bristol, London. It was built in 1996, which means we've had 2 decades and a bit to look at it and be able to see what its validity rating is. Does it actually work in the manner that it was designed to work in? And can we use it to give our doctors a better understanding, to give our medical professionals, our caregivers a better understanding of what my loved one can actually do? Caregiver, understand that what you're experiencing is very real and what you're experiencing is very damage. And the only difference is if a person has Alzheimer's, their brain is damaged in a different order and fashion than a person who has frontotemporal dementia, even though those two dementias may later combine. So this scale was built for persons with dementia. We've had a long enough time to look at it. Its validity rating is now at 98%, and it gives medical professionals a true picture of what your loved one's actually capable of. And the reason is it takes both components of the instrumental activities of daily living, and it takes components of the activities of daily living, but then it added in the steps and the breakdowns and the step downs that you as a family caregiver need to have noted and has a better understanding of what you're actually dealing with. When you take your loved one to the doctor, something, and Chris and I have talked about this before, as a family caregiver, you have pride in them. You have pride in their appearance. You have love for them. And so on the day of the doctor's appointment, you got them up a little early. You got them clean shaved, or you got her lipstick on. You got their hair fixed. You got them bathed by hook or by crook. You got them clean. You got them dressed. You fed them. You got them out to eat it. I've actually been in someone's house when they found the food in their microwave and attempted to eat it, and the food had turned green. It wasn't the right color. Then the next step down is the person able to prepare ingredients if they're set out? So as a family member, you may have noticed that if you have to run an errand, but you leave the stuff to make a sandwich out or to make some stuff out, they can do that. But then you realize there's another step down coming where the person can only prepare food if you're there right next to them, doing it step by step by step. And then from there, the person is really not safe to attempt to prepare food, to be able to prepare food safely, to use a knife, to use sharp implements, or to turn on a stove or anything that has heat or power to it. And the other answer is non-applicable because your person hasn't gotten there yet, or because something else is going on with them. Is that making sense, Chris?
That is.
Okay. Now, on Dr. Katz's scale, eating was called feeding. And in our particular profession, we have a great deal of problem with the word feeding because it just sounds so institutional, and it's something we've really tried to get out of our vocabulary. It just doesn't have a good implication. So in the Bristol scale, we use the term eating. And in the beginning, it means that your person can eat appropriately with the correct cutlery. And what that means is they can cut their meat. They can lay their knife down. They can then use their fork to stab their meat and bring their meat to their mouth. And the meat has been cut into the appropriate size for them to bite and chew. It means that if they're eating something that requires a spoon, like soup, that they can do that without spilling it all over themselves. People with dementia eventually have a great deal of difficulty eating anything liquid with a spoon because it's just going to end up all over them. Plus soups, we need more calories than that, and we try to go for that. So after cutlery is no longer used, then the person is able to eat the food if you make it to where you've already cut the food up for them, or they're beginning to use a spoon, but you've provided them with the spoon and you've prepared their food to where it is already cut up. And that's where we would use something that we would call mechanically chopping food. Right in there, and these two can sort of overlap each other or be backwards to one another, the person begins to eat finger foods. And if you'll remember, as you look at this, we're going backwards from how a baby learned to eat. And now we're going from an adult back to that final part where the person actually needs to be fed by another adult. Does that make sense, Chris?
It's interesting. Yeah, it makes sense.
Okay, so during this decline, we go from regular plate of food to where we're actually going to cut your loved one's food up into bite-sized pieces for them. But then we're going to have to go to finger foods, and then we're going to be mechanically chopping foods. And from mechanically chopping foods, where we're doing what the teeth do, we're then going to move to pureed food. Now, remember that when we serve your loved one a pureed meal, it's not leftovers from last night. That's actually against regulations. It is the food everybody else is having right now. And what we want to make sure you watch, we watch for everybody, is that everybody's food is prepared in the best way possible. Nothing is stirred together into gray goop, and that the food, when it's pureed, is still tested for seasoning, because we know in other communities they don't do this. And if your food is not properly seasoned, I could make Chris the best steak in the world. If it doesn't have salt on it, he's not going to enjoy the steak. And we want him to be able to eat as much as possible for as long as possible. And when we do planning for scheduling, one of the things we always have to look at is it takes about an hour to feed a person with dementia their meal, because of how much slower their body is moving, how much slower it is to get the person to take the food, to chew the food, to safely swallow the food, to make sure nobody's chipmunking or having any other kinds of difficulties. And so it's quite a skill for a caregiver to learn how to do that and do that patiently. On the original ADL scale, we didn't have things like drink. We just had feeding. So now it's that the person can select and prepare a drink as required, that the person can prepare the drink if the ingredients are set in front of them and made available for them, that they can prep the drink. And that would be, Chris, where I'm no longer telling my mother to make the iced tea. I'm now doing things like asking her to set the glass on the table, or before that, maybe put the ice in the glass and set it on the table. But if I prompt step by step, she can do that until finally the person's not able to make a drink, even if I'm trying to stand there and help them in every way possible. Now, everybody watching, I want you to notice something. When I put into my computer today, older lady drinking, I got this lovely lady with hair that I like to think is my color, and she was drinking a glass of milk. Okay, you with me, Chris? I also put in a man drinking, and this is what I got. So I thought it was unusual that those were the two representations we basically had. And I think he's actually having a beer from y'all's part of the world. But in the beginning, drinking means that I drink appropriately. I know how much fluid I need a day. I know that I need to drink water or something without caffeine in it. I'm not drinking alcohol all day long, and that is something that we certainly do see in our population that we work with. And then it means that I can drink appropriately, but I can only drink with an aid. And an aid means that I'm now having to use a straw or a cup that has only a small opening on it for me to sort of suck at in order to get my fluid. Then I don't really, maybe I try to drink, but I can't drink appropriately. And what that is Chris, you and I see it as a loss of coordination, where the person tries to bring the glass to their mouth and they miss their face and end up pouring their drink on themselves. And that's a common thing that we see, but it's also very normal until finally the person can only take a drink if we hold the glass to their mouth and put the straw in their mouth for them to suck. And that's because suckling is such a primitive brainstem instinct in humans that it's how we get people to drink. And so drinking begins to, and by drinking, we mean fluids, not beer or stuff like that. But it also begins to change. And so family members, as you're watching this, you may have noticed that your loved one has stopped drinking, and it can be because they don't understand how to go find the drink, or because they don't understand how to bring the drink up to their mouth and to safely swallow. Now, in between the scale tonight, I wanted to put in some tips that I know that I've learned in my career. So we have the 90-second rule and the 30-minute rule. About 90 seconds after a human has food, the bladder needs to void. And so that's why in the morning you have coffee and now you need to go pee. And the rule of thumb is, this is how humans were taught to be potty trained. This is how we housebreak a dog, is after they eat, we put the dog outside, and after the baby has food, we know that something's going to come out of the body because you put something in, something comes out. Now, as dementia increases, the time between when I finish breakfast and when I need a bathroom begins to change to where I need to be in a toilet situation about 90 seconds to 5 minutes after I finish a meal. I've got a real good chance of having this person toilet on the toilet, which is much easier for all of us and better for them. The second rule is about 30 minutes after a meal is when the bowels will begin to move. And these may be uncomfortable topics, families, for you to talk about, but it's stuff we have to talk about. We need to know how often does your loved one have a bowel movement normally. Some people have a bowel movement once a day, twice a day, once every 3 days. Some dementias cause constipation. Lewy body and Parkinson's disease dementia have constipation as part of the disease. Some of our elderly have constipation because of medications they're on, because there's not enough fruit or fiber in their diet. And so we always have to keep track of people's bladder and bowel movements because we can't give good care otherwise. And one of the ways we do it is knowing what your loved one's normal routine was. When were they most likely to have a bowel movement? And then we know that when we finish meals, we all hustle to get every resident to the restroom, toileted, cleaned back up, and back to an activity. And it's because we know that's how the human works. Now, the next thing is a dehydration check. And when I'm teaching at conferences to professionals, one of the things I'll ask is, how do you do a dehydration check? And people will inevitably yell at me, you pinch the skin. Well, the problem is these aren't 6-year-old children. And once you pass a certain age, you can't pinch skin. This is old white skin. It doesn't pinch, it doesn't snap. It's just doesn't happen anymore. So instead, what you do is, and Chris, I'm going to demonstrate it for you. And I purposefully have not had fluids since about noon today because I wanted you to be able to see this trick when I do it. But what I'm going to do is I'm going to press my thumb very firmly on my forehead. Now, I wouldn't do this to myself, Chris. I would be doing this to you to check you, or I would be doing it to every resident at the table to see who needs more fluid this afternoon. Who can we try to get to drink more or eat more Jell-O or have more watermelon or whatever we can find fluid-wise for this person. So I'm going to ask the person if I can touch above their eyebrows, right above the eyebrows. I'm going to press firmly, firm enough that I would actually put my other hand at the back of the head, and I should be able to feel the skull clearly beneath my thumb. I'm going to press hard for 5 seconds. When I remove my thumb, Chris, I'm going to snatch it away. And if you can see the outline or a white flash or a white spot, even if it occurs for a second, it means that I need fluids. And it's the same thing for a person with dementia. It means that they need fluids. The darker the skin is, the faster the flash is. The longer the flash or the white area stays, the more hydration this person needs. So when I remove my thumb, you should see a clear circle of where my thumb was. You ready, Chris?
I'm ready.
Chris is like, this is so much fun. Okay. 1, 2, 3, 4, 5. And there should have been a very clear white circle where my thumb was.
We need to get you a glass of water, Dr. Tim.
Was waiting to do that, and I've got water right here to drink. And so that's how you check. If you go up and pinch a person with dementia, an older person's skin, you're just going to get smacked. But if I go around the table real quick and say, can I check your eyebrows? They'll let me do that, and then I quickly know who needs stuff. Now, dressing. Chris, this is one of the things where families tell me, oh no, he still dresses himself. And I say, yeah, explain to me what that is. And they usually realize they're somewhere at the second one or even down at the third one. They don't realize that as part of losing those instrumental activities of daily living, somewhere along the line, they begin to lay clothing out for their loved one. And in professional care, we're taught to say to the person with dementia we're doing care for, do you want the red dress or the blue dress, the red shirt or the blue shirt? But then later on, we realized that because of brain death, because of decline and the progression of the dementia, that we're going to dress this person in what we know are their favorite colors and their favorite clothes every day. But what families will do and what families will get very angry about is that your person is putting their clothes on incorrectly, inside out, that they're wearing dirty things. And that's not an unusual thing to happen because it's part of the brain disease. They don't realize they wore these clothes the day before. And back when they were growing up, you didn't wear clothing and then go put it in the dirty clothes because mama had to wash that by hand. You wore clothing and then you hung it up. The problem is because of the difficulty with eating, those clothes are very dirty and obviously well worn, but because of visual problems and the progression of the disease, your loved one can't actually see that their clothing is dirty. And if I told you, Chris, you've got on a dirty shirt, are you going to be happy with me or did I just insult you? So when you see this behavior, it means that they've declined from a person who can dress themselves appropriately to a person who's wearing clothing inappropriately. And that also includes layering clothing because as part of the disease process, your loved one's parietal lobe is damaged. Their body temperature is not where it should be. It's too low. The normal body temperature in late stage dementia people is between 97 and 95 degrees. And so they are colder than you and I. And that's why it's not unusual, even in Texas in August, to see a person with dementia dressed like they're in Michigan or Ohio and it's the middle of winter. And so when you've seen them with their clothes on wrong, they're not doing it on purpose. They're not doing it to frustrate you or upset you. They're doing it because they don't understand and have the brain structure that holds in the memory of how to put clothes on correctly. And the dirty clothing, that's just a lifelong thing of we don't automatically take all our clothes to the wash because mama said wear it until it was really, really dirty. And all of this is occurring because of brain damage. Finally, the person is not able to dress themselves, but they can still move their arms and legs to help us. Although usually at this point, they're beginning to get a little more aggressive and combative with the person who's trying to assist them because this is now beginning to be a little more intimate in care and they don't understand why we're doing these things. And then finally, the person is not able to assist and they require total care by the staff in order to be able to be dressed and dressed cleanly every day. So for dressing tips, family members, you want to make sure everybody's going slowly and gently. You want to make sure that we're doing the same thing that we do for children. We don't dress children in the silence. We don't do their activities of daily living in dead silence. We say their name every few seconds. We tell them how wonderful they're doing. So praise every step. And Chris, we work with a population of people that hurt. So if I know I'm going to hurt that elbow that's got arthritis in it, I'm going to apologize before I hurt it, while I'm hurting it, and after I hurt it. I was actually in a really, really nice community recently. And as I walked in, I saw a private attendant with an older gentleman. And we sort of came in together at the same time, and he sort of shuffled back, and I think she was trying to sort of steady him, but when she did, she poked him, and he jerked his hand away from her, and he said, "Ow, you hurt me." And she never apologized to him. And so much of the time, that's all we've got to do is apologize. If I'm going to hurt you, I'm going to apologize. It's the same thing you would do for me. And we see it not necessarily done with our elderly. So when we hurt people, we apologize and we say we're wrong. And that's what you do for your loved one as well. We tell people you look great. I make it a personal responsibility that every community I go into, I say something positive to every single resident. You've got gorgeous eyes. I love that jacket. That sweater looks great. Your earrings are fabulous. It cost us nothing. So give the person praise for how good they look as you're dressing them. It makes the whole process easier. When you have to set them in a chair or a wheelchair, even in a car to travel somewhere, you've got to make sure everything is smoothed underneath them. That really will cause skin irritation. That can cause a wound to break out. They remember their skin is thinner and they don't move as well as you and I do. And so a simple wrinkle can cause some things. We always dress your person for warmth. And remember, when you're doing dressing, whether it's at home or whether you've turned care over to us, we are making sure that we always, always remember the joints hurt, and that this very simple task of dressing, which is actually dozens and dozens of steps, but you and I have a 3-pound brain, it can hurt the resident. And that's why we go so slowly. Hygiene is number 6, and this is your ability to be able to wash regularly and independently. And after that is that the person can wash themselves with a setup, and then they can wash with a setup if prompted and supervised. And what that means is I've given them the towel, the soap, I'm opening the shampoo, I'm checking the conditioner, I'm helping with all of these steps until finally the person is not able to wash themselves. And one time I was at a lady's house for the state, Chris, and I said, "Does your husband bathe?" And she said, "Oh yeah, he goes in there every day and bathes." And I'm looking at the gentleman in his dirty clothes. And I said, "When's the last time you saw a wet towel?" And you could see a light go off over her head. She wasn't trying to be bad to her husband. She was so exhausted that when he went in and shut the bathroom door and was in there for 20 or 30 minutes, it was a chance for her to take a break and get a breath. And she was so exhausted, Chris, that she couldn't realize he's not actually bathing. He's just in there running water because all he knew to do was turn water on. He didn't understand all of the other 4 dozen steps there are to be able to take a bath and to clean yourself. As you think about hygiene, under the old Dr. Katz's, I don't mean to say old Dr. Katz, under the old scale, Dr. Katz's activities of daily living, we had grooming. And grooming came after bathing, but grooming is part of hygiene. It's also part of bathing. It's also part of dressing. It's also part of good care. That's things like hair, combing hair and fixing hair. And understand that even when we say that in stage 6, people with dementia look very disheveled even after we comb and brush their hair. They just look disheveled, and we don't quite understand why. Grooming means hair gel, hairspray, hair products, being able to shave your face, your legs, under your arms, wherever it is that you shave, being able to use makeup and use makeup appropriately, being able to brush teeth or care for dentures, glasses, hearing aids, using deodorant, a perfume, or a cologne. Grooming is also extremely complex, and I didn't even break down all the steps it is to do makeup. How many different things a woman does to do her makeup. And so grooming is another very, very difficult thing. So tips to use: if your loved one is still at home and they need a shave, use a warm washcloth to prepare his face, to soothe him, softens the skin, softens the beard, makes it easier to get a good cut. And make sure that you're always respecting the dignity of this loved one. If he was a clean-shaven man, then he should be clean-shaven. Women shouldn't have hair on their chins. So these are things that we take great pride in, but be aware there are ways to do this that it helps make the job a little bit easier. For brushing the teeth, in time, your person's going to tell you that toothpaste burns their mouth because it does feel like burning to them. That fresh minty flavor that Chris and I use, it begins to feel like you've put something bad in my mouth. So switch your loved one to children's toothpaste. It's super sweet. It comes in candy flavors. And if they eat the whole tube, it's not going to hurt them. When you do their makeup, you want to make sure they look their best. Ears always clean. Those are actually things I look for in communities. Are the ears clean, or the nails clean, or the hands clean, or is their mouth clean? And when you look at nails, remember, if your loved one's diabetic, you can't do their nail care. Only the RN, only the nurse can do their nail care because we have to be very careful with them. Other things are belts, scarves, shoes. Understand how complex it is to get dressed. And you and I do it automatically because it's procedural memory, but for your loved one, it's dozens and dozens of steps that are gone. For drying skin, we don't rub skin, we pat skin. We deal with much older people and their skin doesn't get rubbed. That can tear the skin, so we pat them dry. Make sure we've got great lotion for the skin. And when we start touch, we don't just put hands on people. You start with fingertips to make that skin aware that there's someone else there, and then move to put lotion on. Now, okay, so when I was looking for the photographs for y'all today to build your slide, first I found the woman drinking milk, and of course the man was drinking a beer. When I looked up teeth, the nose hairs in this made me laugh, and I thought maybe at this point we would all need a laugh, so this was the picture that I picked. And so it means that the person can clean their own teeth or dentures and do it correctly and properly. Then the step down is that they can clean their teeth if you give them the toothbrush and you take the toothpaste. Then it means that you're putting the toothpaste on the toothbrush and you're either getting them started with the brushing movement, or you're actually having to move on down to where full assistance is happening to where you're actually brushing their teeth. And teeth health is very important in dementia care because the cavities that are right here around the teeth, the mouth, the sinus cavities, those cavities open right up against the brain cavity. And so infection here can easily cause more damage or bad things to happen to your loved one because of the proximity of those two areas to each other. Bathing and showering, these are our most complex ADL. This is more than 4 dozen steps to do. This took you and I as children 7, 8, or 9 years before our mothers believed we could safely and correctly bathe. It involves a primitive brain response as dementia progresses to where the person may react to getting wet means getting cold, and getting cold means getting sick, and getting wet and cold and sick means dying. So there may be a primitive instinct like that. Showers that might feel very invigorating to a young person can easily feel like 1,000 stinging bees to somebody with dementia. And in showers, intimate care is required. The person may have to be naked. We're having to clean areas that our entire lives, for as long as you and I can remember, we've been told not to allow people to touch us in those places. So bathing can be very, very challenging. Now, on the Bristol scale, the bath or shower means bathing regularly and independently, what you and I do. Then the person will take a bath if I draw the bath for them, or if I turn the shower on and get the shower ready for them. Then they need supervision and prompting, and then they're totally dependent and need supervision and assistance. And as you looked back on hygiene, you saw that these two were very closely intermingled together because they're almost the same activities, and they involve many of the same or similar steps that are occurring. But at the end of the day, Chris, what is the purpose of bathing? Is it to make someone so angry, so frightened, so upset that it takes them 24 hours to calm down? Or is the purpose of bathing to clean skin?
Clean skin.
Absolutely. And we don't have anybody out working on the railroad. So we can clean skin today. If that person is that agitated, the best thing today might be a bed bath. The best thing today might be that we only get 1 or 2 arms cleaned, or we get their hands and their face washed. But we have to pay attention to our behavior also as a way to help this person be able to safely and easily take a bath, because it is intimate care. So for one thing, we don't need to talk about it. I don't need to say, Chris, we're going to go have a bath. How about a bath? Doesn't the bath sound fun? We're going to go down that room and just a little bit. You'll be naked and we'll go have a bath. It'll be a bath, 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 bath. And you've been agreeing with me because I sound so pleasant. But what I didn't realize is you didn't understand but a few words of what I was saying, and I seemed real animated. So you were responding to that, and you had no idea till we got down to that room what was fixing to happen. So we don't need to talk about it. We just need to get everything ready to go do it. We need the room to be super, super warm. We're having to undress somebody and put them in water. We need the room super warm, and they're already super cold. You got to have everything there and ready for them. We cannot leave your loved one in a shower and then remember, oh, we got to go get something because they're not going to be there when we come back. We cannot do that. We have to have everything ready. We now have things like modesty robes and modesty towels for people who are extremely modest. And these are sort of terry cloth robes that go around a person. The person feels like they have a robe on, but the sides are open to allow the caregiver to be able to bathe this person in as easy a manner as possible. As we bathe people, we talk to them, we use their name, we sing songs, we sing Twinkle, Twinkle, Little Star, we sing Happy Birthday, they're the same lyrics or the same melodies. We sing Jesus Loves Me, This I Know. We sing little songs that you and I learned as small children to help get this person distracted as we go through this ADL that must be done to keep this person as calm as possible. So use their name, and at the end of the day, realize we're just trying to get skin clean the best way we can, and without causing making this person unduly upset. Now, toileting means that I can use the toilet correctly every time when required, that I recognize my bladder or bowel are full, that I know where that bathroom is, that I know when I get in that bathroom, all the things I have to take off, undo, how to use the bathroom, how to clean myself, how to flush the toilet, how to come back and go back to doing what I was doing before. That's what using the toilet correctly means. And if you've been a family caregiver, you probably noticed when your loved one had their first incontinent episode. And you just thought of it as an accident. And then later on, you realize there have now been 2, and now there have been 3, and now it's happening every month. And then it begins to happen every week, and then it begins to happen at night. And then all of a sudden, the person seems to be incontinent, when in actuality, that's a process that took place over a pretty good period of time, a couple of years even. The person in the beginning can use the toilet, then we notice they need to go to the bathroom, or we know that right after meals we need to get people moving to the bathrooms. Then we notice that the person is incontinent of urine or feces, and it's either or, because typically in stage 5, the person is incontinent of bladder, they're incontinent of urine, and in stage 6, they become incontinent of bowel or incontinent of feces. But some people may have had a stroke, they may have had another condition that kicked in, their particular brain disease may have gone slightly different. And so in some people, we see in stage 5, they become incontinent of bowel first, followed by incontinency of bladder. But eventually the person will be incontinent of both bladder and bowel. And that's not because they're too lazy to go to the bathroom. It's because their brain no longer gets a signal that the bladder and the bowel are full, and the person is not even aware that they avoided themselves. It is not purposeful behavior. It's nothing they're doing to upset anyone. You have to remember that this is some of the most complex brain activity that we have in terms of connections of holding feces or urine in, and then being able to release a sphincter on command, and being allowed to do all that after I got things unbuttoned, unzipped, unbelted, after I got things down, after I sat down without feeling like I was falling. So I have to know my bladder or bowel is full. I have to know the location, be able to remove clothing, and then I have to be able to finish and go back to doing what I was doing before. And it doesn't mean I'm trying to be bad. It is just the progression of the disease. So as we work with people, as you work with your loved ones, you have to remember modesty. Intimate care is always going to be challenging. Social skills are in play here. You want to keep talking. The more I can talk, the more I can distract, because I can be with somebody so modest that they can't get their bladder to release because they're too modest and the sound is going to upset them. And then that makes their sphincter tighten back up and their bladder closes off. So I'm going to keep talking. I'm going to run water. This is no big deal. And we always pay attention to when bowel movements occur because that's part of giving care. We need to know when these things happen so that we can make sure your person gets the best care possible. And we're always operating under 90-second rules and 30-minute rules to make sure we get people taken care of. Now, transfers. In Dr. Katz's scale, transfer was the first thing on there. And the reason is transfers, one of the first things you and I did, it's a developmental milestone. It meant that we turned ourselves over as infants. But in our world, transfer means the ability to get in and out of a chair or a bed unaided, to be able to move from a sitting to a standing position unaided. And then as the disease progresses, the person can get into the chair, but they can't get out of the chair unless you or I help them. And then they need assistance getting in and out of the chair. And remember, this is also a time, transferring can be very scary for your loved one, especially transferring down to a toilet seat, because toilets can be lower and they can feel like they're starting to fall. And they can also feel that way in a chair. So just be aware that that's a normal thing. And that's why we're constantly reminding them to reach behind them, to hold on to the arm as they prepare to sit. Even though they've stood and sat down a million times in their lifetime, now because of brain damage, those pieces are gone. And so we're going to try to fill in those little spots for them. And then finally, the person is totally dependent upon us to get into or out of a chair, into or out of a bed, into and out of any type of care that's required. Now, in the beginning, this was one of the first milestones. Those of you who are new parents, those of you who are parents, you remember the day your first baby turned over was such a big thing that you actually got on the phone and called someone to tell them. And that, Chris, was way before your time. That was back when people didn't use the phone unless it was serious business. And so one of the first things a baby must do is be able to turn itself over, or it means that their brain is not developing correctly. And from that transfer, we went on to being able to stand and ambulate and beginning to move. But now as we transfer people, especially as the disease progresses, we not only recognize the step down of what they're able to do, but we also have to remember that even though you think your loved one looks very hale and hearty and they haven't started losing weight yet and they're still in really good shape, we're trying to tell you that due to their brain damage, they are very fragile and very frail, no matter how robust they may seem or appear to outsiders, even to intimate family members. And it's because you're seeing them with your eyes of love and we're seeing them with professional eyes. When you talk to your loved one, when we talk to your loved one, we use their first name and tell them what we're going to do before we do it. Nobody wants to be jerked up out of somewhere. We explain what we're going to do. We use the person's name. We do a 1, 2, 3 count, and then we lift. We all have to remember that as we age, when we sleep, our joints gel up at night. We're not limberly people anymore. We don't leap out of bed. That's 6-year-olds that leap out of bed. I sort of drag and crawl out of bed. So we have to give everybody a few extra moments as we do any transfers, especially morning transfers from the bed up, because those joints have gelled in the night and they take a few more moments to start working. Some of you may have even noticed that as you aged, you went from getting out of bed, standing straight up and walking off, to getting out of bed, sort of bent over, and you don't really get to your full standing position until your 3rd, 4th, or 5th step. Just remember, gentle. Be very, very, very gentle. Mobility is what Dr. Katz called ambulating, and mobility means the ability to walk independently. But then the person with dementia begins to slowly start walking using assist. And Chris, the assist can be as subtle as nobody in the family has realized she's using the back of the sofa to balance and move herself through the living room. And so as you watch people with dementia in their homes, they've naturally begun to look for places to give them support as they move, or they will begin to use the arm of their caregiver for support. Then they'll begin to use things like a walker or a cane or a stick to be able to help themselves stay in balance as they move. And then the person unable to walk gets moved into a wheelchair setting. Now, when we see a person at this stage, we don't say, oh, they need physical therapy. Oh, they're not trying hard enough. Oh, if they would just get up and go. They can't. They have brain damage. We want them to be as comfortable as possible, as mobile as possible, for as long as possible. But when they can no longer do those things, we're then going to put them in a wheelchair and try to keep them as safe as possible. And one of the things that's very hard to grab onto is that even when your loved one is bedbound, their risk of falls from mobility, trying to get out of bed, continue to go up, even though they may not have been walking for several months. There continues to be an urge to try to get up and move, and we don't quite understand this. So as you work with your loved one, as we work with your loved one, we know that it can hurt to move. I hurt right now. We know that she's frail and fragile. We're going to go slowly. These bones are old. Remember, I'm in my 60s, but I'm actually in my 7th decade of life. If you're in your 70s, you're in your 8th decade of life. People in their 90s are in their 10th decade of life. These are older humans. And so we have to be aware that not only do the bones hurt, not only is there arthritis, tendonitis, bursitis, all kinds of other things that make bones or joints hurt, but this person also has brain damage. They don't hear well and they don't see well. Use all your social skills. When you visit your loved one, when we're working with your loved one, we are using social skills, and that includes using their name and lots of praise over and over and over again. 12 is orientation, and it's orientation to time. Time is that you're fully oriented to time, date, place, and self. You know who you are, where you are, why you are, and where you're supposed to be. But then the person begins to very slowly be unaware of the time or the day. And they may put a big calendar up on their wall to see what's going on. They may do all sorts of things to try to give themselves clues, but eventually they will be unconcerned about what day it is. And when I ask them what day it is, they'll laugh and say, oh, well, I don't care. I don't work anymore. They'll come up with a humorous answer as a way to get out of answering the question. Then they may suddenly flip as they slip downward into constantly asking what time it is, what day it is, what date it is, and this can cause quite a bit of anxiety. Then the person begins to mix up their day and night, and this is due to their circadian rhythms in our body functions are in all of our cells. In you and I, those cells rhythms are running together. The person with dementia eventually has so much brain damage that their rhythms are not running together, and they begin to mix up day and night. 13 is orientation to space. Space is that you're fully aware, you're fully aware of your surroundings. Then you're oriented to familiar surroundings only. And Chris, where you and I see this is the person, the family says, I tried to get them to come and they won't come. I tried to get them to go on vacation. They won't go on vacation. I can't get them to go to this thing. I can't get them to leave their house. And that's a normal thing to happen because on some level, the person is aware that if they leave their house, they will be lost and other people will be able to see it. So we don't quite understand it, but we recognize this as a normal behavior in people with dementia. Then the person begins to be lost in the home, even the home they may have spent 50 or 60 years in. And then the person does not recognize that this physical structure they're in is their home, and they begin to attempt to leave it. In their home they're looking for at that point is the home of a little kid, a 2-year-old to a 6-year-old to an 8-year-old, a little niece or nephew who came to spend the night with you, Chris, and loved you wonderfully until 8:01. And at 8:01, they didn't care what you'd done for them. They wanted to go home. And they didn't mean home, a physical structure. They meant the comfortable things that make home home. Our pillow, our sheets, our bed covers, our favorite art, our chair, our smell, cologne or a perfume, and pictures of family. And then the person families can get so frustrated by this that you think, well, if I just take her and show her the home she grew up in, then she'll quit asking to go home. The problem is when you get there, they're going to tell you that's not home either, because again, it's not a physical, tangible structure. It's those other 7 things that make a space home. Communication and the scale, they can hold an appropriate conversation. Then that means, Chris, that you understand what I'm talking about now, how it ties into what we just talked about, and what the comprehension of this conversation is. Then the person shows understanding and attempts to respond verbally, and will attempt to respond verbally with gestures, or they'll appear to understand and then they'll begin to get lost in the conversation. And so they'll make a polite social chuckle to cover that they don't really understand what we're talking about right now. Then in the next step down, they can make themselves understood, but they're having difficulty understanding what you and I are saying. So you have to go back and remember in stage 5 of the disease, which is moderately severe dementia, the person understands at the beginning 3 out of 4 words and has the ability of a 12-year-old. By the middle of stage 5, an 8-year-old. By the end of stage 5, they are the equivalent of a 4-year-old who understands 1 out of 10 words. So they can make themselves understood to a point, but they're not understanding what we're saying. And then finally, they're not able to communicate with us in language, but they still understand body language and our tone and pitch of voice. Humans do about 90% of our communication through body language and tone and pitch of voice. Telephone. Now, Chris, this is one that's going to change because this tool was built in 1996, and in 1996 we didn't all have computers, but in 2007 we all got one of these, and this is a little computer. And now we have one of these, we'll have one of these, and if I turn the screen around, you'd see 3 more computers behind me. So telephone and computer are being looked at as sort of being the same thing. So in the beginning, your loved one may have used the telephone appropriately, could use the computer appropriately. Then they could use the telephone if you did the number for them or wrote the number down for them, or they could use the computer if you turned it on and got them started. Then they can answer the phone but can't make calls. Then they don't know how to use the computer anymore. And then they have no interest in the telephone. They don't know what you're trying to do to them, and you can actually annoy them by that. So telephone and computer are something we're expecting to be combined. Housework and gardening begin to change from where the person could do what they previously did to they can do the work, but it doesn't look like it used to. That pristine yard that she kept perfectly gardened like a picture is now disheveled looking. Things are beginning to pop up that shouldn't have popped up. And then the person will do some things, but it requires a lot of support from the caregivers or the family around them. And then they're unable to be a part of the activity anymore. For example, if we had a person whose dementia was advanced enough and they used to love to garden, now when we take them out to garden, they may try to eat the dirt. So they've passed the point where they would be willing or able to participate in the activity. Shopping is that the person can go from shopping to their previous normal standards to where they can only shop for 1 or 2 items with or without a list. And it's with or without a list, Chris, because some people make lists. If you make a list, that doesn't mean you have dementia. That just means you're a list maker. It's nothing to be worried about. And then the person is unable to shop alone, but will participate when accompanied. And that's why in memory care, we take people shopping, because they still like to go shopping and we want to be able to enjoy that until finally they're not interested in it. They don't understand what it is, and they're not able to participate in it. Another thing you have to be aware of with shopping is that because of dementia in stage 5, the person doesn't necessarily buy 1 comb, they buy a dozen combs. They buy multiples of items. Every time they go to the store, they keep buying the same sets of things. And so when you come in to see your loved one's house, you wouldn't necessarily be surprised to see multiples of certain things. And what you're witnessing is a failure in the scale for shopping, but you're also witnessing at the same time the advancement of the disease under the behavioral staging tools. Does that make sense, Chris?
It does.
Chris says, yes, I'll say anything to get through here tonight. Okay. 18 is finances. Finances goes from the person is responsible for their own finances at the previous level that they understood and did their finances, to where the person can't correctly fill out a check, but they can sign their name and they recognize money has value and what that appropriate value is, to where they can sign and will continue to sign their name, but don't recognize the value of money. And that's where we have to be very careful and make sure that we provide an extra set of care around our loved ones to prevent bad people from taking all of their assets, to prevent them from giving away their assets to people who are happy to take it, especially when the person is able to still sign their name to a check. And because they still don't look physically sick, nobody at the bank questions it, but somebody who should not be getting money is getting money. So we always have to be very careful. So you've got to remember that your loved one, given the right circumstances, a person can get them to re-sign legal documents. It can cause them to give away the assets to strangers or to bad people or to bad family members. I'm sorry, my slide shifted and you can't read it. And you have to realize that there are people who prey on the elderly. There are people who prey on people with dementia. So always be proactive. Always make sure you've got your paperwork signed, you've got everything notarized and registered, and that you're keeping watch over your loved one. Number 19 is being able to do games and hobbies in the way that the person used to do them. And then the person begins to be able to still do the game that they love to do, but now they require a lot of supervision or assistance to, and that's not something that just happens in a week. And Chris, my example is dominoes. So every dementia person I've ever known that I played dominoes with feels bad for me because I'm a terrible domino player. And so you have to realize when we're doing games with your loved one, our goal is not to win. Our goal is have the socialization and let your loved one win. So in the beginning, the person can play dominoes. They can match 5 to 5s and they can add the numbers and they know how to build the domino form. But as the disease progresses, now they know they're matching doubles. So they're matching 3s to 3s and 2s to 2s and 1s to 1s and 5s to 5s. And it's just going in every direction. And then the person knows that they can still shuffle, but now they're having to have their dominoes pulled out for them and turned up. And now we're having to help them as they play their game and tell them which one to lay down. And then finally, the person is no longer interested in doing the game at all, and they're no longer able to participate. And that is the normal progression of what we do in activities with your loved one, is we're now beginning to break it down, break it down, break it down, break it down, break it down. And then there becomes a point where there's so much brain damage, your loved one is no longer interested. The last one is transport. This is the ability to drive, cycle, or use public transportation independently. Then there is a step down from there from unable to drive, but uses public transportation and bike. And I have to tell you, I have some issues with this one, because here in Texas, if you can't drive, I promise you, you also can't ride a bike. And because of the amount of balance that takes, I have some questions about that particular part of the scale. And then the person is not able to understand or use public transportation correctly. And then they're unwilling to get on that bus or do that activity, even if accompanied by someone. And so again, this is just the normal progression of the step down. Now, real quickly, I know we're right at time. I want to give you some steps that we use to get people to bed. There's 4 bedtime steps. We want the person to be toileted. We're going to wash their feet. We're going to say their nighttime prayers, and we're going to use a magic phrase. Now, the reason for this is that older bladders are folded bladders. Bladders are no longer springy like they are when you're younger. Instead, over time, ladies, every pregnancy you had, that baby sat on your bladder. And gentlemen, prostate enlargement causes your bladder to also become folded. And we need to get the bladder empty. So the first thing we're going to do is put your loved one on the toilet to pee. And we hear them pee, and you think they emptied their bladder, but they didn't. We want the bladder to be signaled that it is not yet empty. So we're going to brush teeth, and we're doing that now Even if she's still on the toilet, we're going to brush teeth because we want to get water in the mouth because that helps to signal the bladder. But then at the same time, we want to wash her hands and wash, did I just say on the toilet? I'm sorry, I didn't mean that. I said, and then we want to stand her up, brush her teeth, wash her face, wash her hands, because the sound of water, the feel and touch of water should continue to signal the bladder that it needs to void. We put her back on the toilet, let the sink water continue to run, and in a few moments, the bladder should now truly empty. She should pee again so that the bladder is finally empty. And if we do just this few more minutes of care, if you do this care for your loved one at home, it's going to mean that you've got 3 or 4 more hours before the bladder will begin to fill again, which means you might get through most of the night without having to change a person. We know that we are able to do less changes in the night if we use this technique because we truly got the bladder empty. Step 2, I've now put the person in bed. I've got their bladder empty. I feel good about it. Their face is clean. Their hands are clean. Their teeth are clean. Now I put her in bed and I'm going to use a warm washcloth to wash her feet. Now, if you've never done this for yourself or your loved one, do it for them. This is something that their mother would have done because she had scrubbed those sheets clean by hand, and you didn't get in a bed with dirty feet. So you washed yourself before you went to bed. A warm washcloth on the feet relaxes a person. It gives you a chance to clean between the toes and the cracks in the feet. It's an act of love. It's one of our oldest acts and signs of love. And it also helps people fall asleep. And for a lot of our population, it's an old memory of what Mama used to do. The third thing we're going to do is bedtime prayers. Now, I'm not going to try to change someone's religion. I'm going to use the prayer that they're most familiar with. And the person may do a number of things. They may ask me to say the prayer, and I'll say the prayer, and then they'll say amen. They may ask me to say the prayer, and for every line I say, they repeat that line, and then we say amen. They may ask me to stand there while they say the prayer, and then we say amen. But it's a moment of calm for the end of the day. It is a lifetime signal that the day is drawing to an end. It's an old memory of safety and peace and calmness. It's a connection to God or to your higher power. And it means for us that our final day of care is just about completed because we still have to do our magic phrase. The magic phrase is good night, I'll see you in the morning, because growing up as children, you and I both heard this every single night. And what it really meant was don't get out of bed. It didn't mean I'm actually going to be here in the morning to see you. It meant go to bed, stay in bed, don't get out of bed, because getting out of bed could get you in trouble. It means that all is well. It means that you're loved. And so we use those steps to help your loved one be able to get to bed and to have the best night's sleep possible. And remember to do that for yourself as well. Chris, when I check with you tomorrow, I'm going to make sure you washed your feet tonight. Okay?
Done.
All righty. So I hope this helps everybody realize that this is another one of the tools that we use, but this really helps your physician understand what your loved one is actually doing at home. It helps you realize that you're not crazy. You're just watching someone you love with brain damage. And it's so common. It's how we build our tools. So just use the tool because it helps you as you go through this process. Okay, I'm ready, Chris.
Hey, do we have any questions?
Having water now.
That you can put into the chat for us? Or raise your hand if you want us to hear from you.
Or we've all gone home.
We have Donna. First of all, Diane says, thank you, Dr. Cummings. Love your tips and your presentation.
Thank you.
Donna, you should be able to ask your question.
I'm trying to enable her microphone. Just give, oh, it should be okay now.
Hi, Donna, are you there?
Okay, since we can't hear you, if you wouldn't mind typing it, we'll come back to you. We just have another from Sarah thanking you for putting it all together. Very helpful.
Good, good.
Yeah. Amanda? The family member at Chelsea Place, I believe they were doing a watch party at Chelsea Place tonight, Dr. Tam. And one of the members there is asking about those forms. Nicole put all of the forms in this chat as well as attached to the team's registration. If you are looking for the forms and not finding them, please reach out to one of your friends at Anthem, and we'll be making sure you get those via whatever works for you, email, text, or putting them in the old-fashioned mail if that's what you need. What advice would you give to families to prepare them when the utensils need to change, such as now they need weighted silverware?
Well, we want to make sure that the doctors ask that you've spoken to the doctor, that the doctor has given you an order for a speech therapist to come do a swallow study, and that therapist will then watch your person take in food, and they'll make recommendations for it, but it's a normal thing to happen. We do tend to see more weighted utensils with people who have tremors, such as a Parkinson's disease dementia person. We would see more of a weighted utensil used. Other utensils we might see might just have a larger piece of foam over the handle part of it to give the person the ability to grip it better. But the changing of cutlery is common, and the use of not only weighted cutlery, but also bowls that have lips on them to help people catch the food and fall over into the spoon or the utensil. So those are normal things to be used.
And if they are resisting using a new utensil, is there any advice?
Yeah, it's not, it's not resisting. It's the inability to learn a new thing. And so the person is going the same way we couldn't hand little babies in a little baby chair. We couldn't hand them a fork and a knife and say, go to it, kid. They went to finger foods. It is more than likely that your person is now ready for finger foods, but we want to make sure the speech therapist is involved, because that's part of their job to make sure that the food being prepared is being prepared in a safe manner for your loved one. But it is normal for late stage 5, beginning stage 6 people to begin to move into more finger food as a way to intake food.
That makes sense. We have a question. If you do the ADL assessment, do you get a score? And then what does that mean for a family member?
The score is not really for you. The score is for the physician or the medical professional. The Bristol scale is a scale that you would definitely want to take to the physician, just because unless they're a specialist, they wouldn't be familiar with it. But it would certainly give them a much more remarkable understanding of who you're dealing with and the care you're dealing with.
Donna, you should be off mute now. Would you try to ask your question again?
Yes, can you hear me?
Yeah.
Oh, thank goodness. Okay, thank you, Dr. Tam, for helping guide us through this journey. My dad is at an Anthem Memory Care, and before that he was living with me, and getting him in the shower has always been a big challenge. Even though he showered all the time before the dementia, I do feel like he's probably in the stage 5 somewhere, but it's not a straight line. So the caregivers will call me when, it's been day 7 and they can't get him in. But unless I go down there and tell him we're going out, but we're not going anywhere until you get in the shower, and then that, of course, becomes a little bit of a thing, we just don't even know what to do. He says only his wife can see him naked. He thinks he already did it. If they tell him that I'm coming to get him, he says, oh, she'll take me the way I am, which is true. And I always tell them, don't get in an argument with him, because to your point, it's not the end of the world, but it is really a thing. And I just was wondering if you had any other tips or tricks.
Well, one of the things you might do is talk to his physician and let him know that he's very reluctant and challenged because he doesn't understand the need for a bath and why he's doing that. You also have to balance that with how dirty is he really. You also have to balance that with they didn't grow up the way we did. I took a shower this morning. I'll take another bath tonight. So, they didn't grow up the way we did. And so in some cases, rather than us have to have the family member come and threaten their parent, I'd much rather you talk to the doctor about something to take his anxiety level. Just do the Hamilton anxiety scale on him, do the geriatric depression or the Cornell scale for depression on him. Let's look at some mood medications. He may need something that on the day he really needs a bath or a shower, the nurses can do something for him to help him be calm enough that the professional caregivers can bathe him. I think it's hard for children to bathe their parents who are of the opposite sex. That is a challenge. And that's a hard thing for you to have to do. So let's work with your physician and let's, do some testing on your dad. Look at the Hamilton scale for anxiety and see if on the days of bathing, does he begin to exhibit these behaviors? Then talk to the doctor about, is there a way that we can give something to help him be relaxed enough to where the professional caregivers can bathe him, because they do look in all the cracks and we want them doing that work.
Yes, absolutely. Thank you so much for that.
You're a good daughter.
Oh, well, thank you. Thank you for you. And it's in a village, right? It's a village.
It is. It takes everybody.
Donna, I just put the Hamilton scale in the chat, so it's there for you.
Oh, thank you so much.
And Heather Kelly asks if the recording or slides will be made available. Yes, the recording is always on YouTube, on our Anthem YouTube channel within about a week or so of the event. And we typically do also email it out to all attendees, just in a follow-up email, as long as we do have your email. If you don't get it one way or the other, please just call your local Anthem and we will make sure you get a link to the YouTube channel and the recording, so you can share it with your other family members. Absolutely, we'd love for you to do that. And then there's a question on who should be doing nail care when someone is in a facility or in a community. If the person is diabetic, who's the appropriate person to do nail care?
The person who cuts their nails is going to be the nurse or a podiatrist when they come do their podiatry visit. But that doesn't mean that during activities, my mother wouldn't get her nails buffed or polished or filed. We just can't cut unless you've got that license.
For clarifying that. I think we covered everything in the chat. And there's a few more compliments, which we sure appreciate. Is there anything that we missed or you still need to ask?
Let me see. I'm coming to Ohio to see y'all, right? In June?
Yes, ma'am.
Yes, you are.
All righty then. I don't know where in Ohio yet, but somewhere in Ohio.
You'll be in Cincinnati.
Cincinnati. Okay, great. We're gonna have some spaghetti.
Wow.
And chili.
And chili. Spaghetti. Don't y'all put chili
They're
on pasta
together.
and call it
The
spaghetti?
spaghetti
Yeah,
and chili.
I knew there was something odd y'all did in Cincinnati. But yeah, I'm really looking forward to that. I'll get to be in your community and hopefully meet with a lot of your families.
Yeah, you'll be down on June 3rd, or June. I'm sorry, you'll be up on June 13th.
Oh, thank God. I thought it was like
And
June 5th.
speaking
I'm gonna
of
make
date-
a note of that right now. Yes.
Speaking of dates to put on your calendar, our next session with Dr. Tam will be May 8th. I think that is correct. What does that behavior mean is our subject. What does behavior mean on May 8th? You'll be getting an invitation if you are already working with an Anthem community. If you want to be on our list to be notified, please just let your local Anthem community know, and we'll make sure that you're always notified of our upcoming sessions.
Yeah, and the behavior one is really very interesting because we discuss all the behaviors people with dementia have, because all of those behaviors mean something, even the ones that are unpleasant, embarrassing, scatological, that means urine or feces based. There's a reason for everything that the person with dementia is doing, and we're going to be able to help you answer those questions, understand that, and I'm even going to give you guys a behavior algorithm that lets you look at the behavior, track the behavior, brainstorm the behavior, and figure out what is going on, which is something that I'm doing. So I'm going to give you some tools to use that you may not have seen before. So it will be, to me, a lot of fun, but for families, just, a hard one, but it'll help you understand why your loved one's doing those things that might be driving you crazy, might be embarrassing you. It's all driven by what's going on around them or what's happening in their brain. And that is helpful, I believe.
Very helpful. Yep. I think, Nicole, that's all of our questions.
Okay, well, thank you guys again for having me, and good luck to everybody on this journey. Make sure you get with your Anthem memory care and get in the support groups. They will save your life. And as the lady said a little while ago, it really does take a village. So everybody hang in there.
Thank you, Dr. Tam. We'll see you
Thank
next
y'all.
month.
Okay, bye-bye.
Thank you.
Bye.